you can hear the sound coming out of here, then it works. Usually there's about a 10-second delay. So things that you say into here will come out of here. So we know the sound's working, right? And then we just, and then when you see the picture there and hear the sound, then you know the recording's going on. Yeah.
I don't know when people are going to listen to it, they start watching this stuff.
So I'll just share this link with your page, and we're live on the internet.
Do you want the slides as well?
Does Uma have a copy?
No.
Okay,
Yeah.
that's important.
Oh, sorry.
Because
Last time no one could see.
it's a little less pixelated today, which is really good news. But yeah, it'd be good if we could get it on so the lights are on this side. The problem is too is that the line is really flat and like a car. I don't know if you notice it, but after like an hour you really notice it. So this is two. I take a few minutes, but like the lights get dark.
Okay, this seems not as bad. I might head off.
Thanks for organizing this. Alright, I don't want to ruin your house turnout. This is 3 minutes.
No, it's
Huh? Yeah, whenever you're ready. Let's go. And I'll share the link with the others and so we'll work from home.
Alright, hello everyone. Hey guys, we might make a start. Alright, hello, my name is Zoha Farouk, for those of you who don't know me. And today I'll be giving the cardiology revision lecture. So these are the topics that we'll be covering today. And just before we start, I would like to say, I personally kept my slides very succinct because that's what I like to see normally. But for your notes, I would highly recommend you look at Sartak's slides. He's the legend who gave us our lecture last year. So definitely use his slides for your notes. I would highly recommend that. All right, so we'll start. Before we start with ischemic heart disease, I thought I'd talk about the blood supply to the heart. So I don't know if you, you can see, okay. Okay, so the coronary arteries supply your heart, and they come off right after your aortic valve. So if you can imagine, your heart contracts and blood goes up into the aorta. And then the aortic valve closes, and it's during diastole where a lot of the blood actually goes into your coronary arteries. So if your heart is beating very fast, it's not going to allow for that time, the diastole filling time, which is not a good thing. And then, okay, so looking at this picture now, so you have your left and right coronary arteries. And your left coronary artery gives off the left anterior descending, which supplies the anterior portion of your heart. And then it also gives off the circumflex, which supplies the lateral portion. And then you have your right coronary artery, which supplies your SA node, which is really important for the regulation of your heartbeat and your rhythm. And then it also supplies the inferior portion of your heart. This image is really good, I think, because it gives you a good idea of what leads supply what part of your heart. So if you look at the purple part, it's your leads 2, 3, and AVF, and that supplies the inferior portion of your heart. And if you correlate that with what I talked about before, it's your right coronary artery. So I think just putting all of these together can help you figure out where your heart attack is and which artery is affected if you look at all these things together. So ischemic heart disease. This occurs when there's an imbalance between the your heart's demand for oxygen and its supply. And how this can happen is with supply, we're talking about a decrease in your luminal diameter. So things like atherosclerosis, or if you have vasospasm. So if you've ever heard of Prinzmetal angina, that's what's happening, it's spasming, so blood can't reach your heart. And then the duration of diastole, which I explained. So if you're severely tachycardic, again, it's going to affect your supply. And then if you're anemic as well, there's not going to be enough carrying capacity of your oxygen. And then you have the increased demand. So if your heart requires more energy, it's going to put it at risk. So things like hyperthyroidism puts you at an increased risk of this. And then if your heart's hypertrophied, it obviously requires more as well. So I said before, atherosclerosis is actually like the main mechanism for ischemic heart disease, essentially. And the process for this, how it happens usually, is you first get endothelial injury. So if you imagine you have hypertension and there's blood just gushing through your arteries, what can happen is you can get like micro tears within your artery. And then once that happens, macrophages kind of go and like migrate to that area and then kind of eat up like fats and lipids and all of that stuff. So if you have hyperlipidemia or diabetes, that puts you at increased risk because it can eat up all that stuff and increase that process or speed it up. And then there's also smooth muscle cell proliferation, and then that's all contained within a plaque. And so that's the process for the atherosclerotic plaque. And with ischemic heart disease, it's kind of like a spectrum that happens. So you first have the normal lumen, and then you get that plaque formation. And the plaque can grow up to like 70% and occlude your artery by 70% before you get any symptoms, which is pretty shocking, I thought. And then that's when you have stable angina. So when you exert yourself or your heart's like beating faster and requires more energy, because it's been obstructed to that point, you feel that, that angina, the chest pain. But once you relax or take a vasodilator, it's fine. You can get that blood supply. Acute coronary syndrome, however, is when there's like an acute process that happens. So something happens that kind of disrupts this plaque. So you get a little thrombus forming and unstable angina. So it's brought on like even when you're resting or anything like that, it can still come on. And it's more severe in character. And if you take GTN or rest, it's not going to help you. But it's not severe enough to actually cause myocardial damage. So if you do your troponins or your cardiac enzymes, those won't be changed at all. So that's unstable angina. NSTEMI, however, is when there is some damage. So that thrombus does occlude a significant portion of your artery, but it's not enough to cause a lot of damage. So it's just, if you look at that image over there, it's just part of your heart gets damaged. So that's what you see on your ECGs, and then you'll also have your cardiac enzymes elevated because there's some cardiac damage. And then the NSTEMI is when it's completely occluded and you get that full thickness infarct. So here are your risk factors. And importantly, you always need to ask about these kind of 5 risk factors. So if you're ever on the wards or for an OSCE, make sure you always ask about family history, diabetes, smoking, hyperlipidemia, hypertension, those 5 things you must always ask for. And another risk factor is if you also have chronic kidney disease, that puts up your mortality by a lot. If your heart's, kind of at risk and is damaged, and your kidneys are not regulating blood pressure normally, and it's just those 2 in combination puts up your risk of dying by a significant amount. All right, so stable angina, we've kind of talked about why it happens already. The important thing is just knowing that it resolves when you rest and take GTN, and the character of angina or ischemic heart disease, that kind of pain. So it's retrosternal, it can radiate up to your jaw, down your left arm, that sort of thing. It's also associated with sweating, nausea, vomiting, and those sorts of things. Another important thing to always ask for when you're doing a cardiac history is whether there are any signs of heart failure. And we'll talk about heart failure in a bit. And then there's the suggestive signs as well. So those are things like anemia, or if you have carotid bruits, that essentially means if you have atherosclerosis in your carotids, you probably have it in your coronary arteries as well. So those are things you should look out for. Investigations, they're listed. I always break down my investigations into bedside bloods and imaging. That's a good way to do it even in your OSCEs. So if they ask you what investigations would you like to do, always try and break it up into that format. And I've explained why you would do them over there as well. Okay, all right. So management-wise, with stable angina, you just want to do lifestyle. So try and reduce your weight, stop smoking, that sort of thing. And then give them statins or treat their other underlying risk factors. And then GTN if those symptoms ever come on, and beta blockers or calcium channel blocker if that is contraindicated. With stenting and revascularization, it doesn't really improve your mortality, but it does help with your symptoms. So if you have severe stable angina, it's really affecting your life, we can maybe consider stenting you, but otherwise they wouldn't really do it because there's no long-term benefit from it. So then the non-ST elevation acute coronary syndrome, so that's unstable angina and the NSTEMIs. It's the partially occlusive thrombus. That's the hidden process behind it. And what differentiates the two again is whether there's cardiac death, essentially. Yes, so the difference between this and angina is the fact that it's at rest or with minimal exertion and more severe and not relieved. And that is because there's an acute process behind it. So investigation-wise, there might be some kind of non-specific changes, but it doesn't have that ST elevation classically in this as seen in STEMIs. You do want to do your cardiac enzymes as well for your NSTEMIs. And then management-wise, same sort of thing. So lifestyle, manage your risk factors, and then the patient comes in acutely, they're in pain, give them morphine, give them oxygen, dual antiplatelets because risk of forming clots, and anticoagulate them, and then long-term put them on a beta blocker as well. For NSTEMIs, you do want to get them into imaging, so get them an angiogram. But that's not something that needs to be done immediately. It can wait up to 48 hours. Or if they're severely like doing bad, then you can immediately take them. But yeah, so get them in for revascularization therapy as well for the NSTEMIs if it applies. And then on to STEMI, so that's the completely occlusive thrombus, which causes the transmural infarct. And here, the biggest thing is the ST elevation on their ECGs in the contiguous leads. So if it's an inferior infarct, it would be leads 2, 3, and AVF, for example. So you do need to see that ST elevation in whichever region it applies to, or a new bundle branch block. So make sure you look out for those as well, because that can be another criteria. And yeah, and clinical presentation wise, importantly, just look for any signs of cardiogenic shock or the complications of ischemic heart disease, which we'll talk about in a bit. All right. Okay, so the management. There are some acronyms to make it easy to memorize what you do acutely and in the long term. So the acronym for the acute management of STEMI is MONASH. The M stands for morphine, and it's for their chest pain. Oxygen you give if they're satting below 95%. Give them nitrates to dilate their vessels and try and improve blood flow as much as possible. Aspirin, and then S used to stand for streptokinase, which was this enzyme released by bacteria that used to kind of thin out or break down clots. But they don't give that anymore because your body can form antibodies against it, and you can only use it once in someone's life, because as soon as you form those antibodies, you'll react really badly to it again. So now they've changed that to PCI, or thrombolysis. So PCI, ideally you want it done within 90 minutes to try and minimize the permanent damage. But if you're in a rural area where you don't really have access to a cath lab or anything like that, you can do thrombolysis, ideally within 30 minutes. And how they do that is they give a tissue plasminogen activator called alteplase, and that breaks down the clot. So that's what you can do to kind of get the blood flow back to the part of the heart. And then heparin as well. Because nausea and vomiting is a huge feature, you can give them an antiemetic as well, so ondansetron. And then, yeah, okay, so when would you consider doing a coronary artery bypass graft over just doing a PCI? So you guys might have heard of cabbage procedures. So that's when they actually do a sternotomy and join vessels onto your completely occluded arteries, your coronary arteries. And it's done when you have severe, lots of your arteries are involved, or for whatever reason they can't actually stent you. That's when they'd consider doing a cabbage. But normally it is just easier to stent people rather than put someone through an open heart procedure. Long-term wise, again, you want to treat their lifestyle factors, so stop smoking, diet, exercise, all of that. And then medically, the acronym is SAB-C. So give them a statin, and give them an ACE inhibitor, because that minimizes left ventricular remodeling. So what that means is after your heart has infarcted, it kind of dilates and changes in a not effective manner, and that impairs its contraction in the future. So you want to minimize that. So that's why ACE inhibitors are really important. And then give them aspirin beta blockers and then clopidogrels as well. Okay, so complications. If he had a STEMI and it's that transmural infarct, you can imagine that it could actually rupture and blood can just go into the pericardium and actually cause tamponade, which is really dangerous and can kill people. So that's a severe complication. Another one is mitral regurgitation. So this is the most common valvular kind of disease as a result from heart attack. So that's really important to remember. It can come up in questions. So what happens is the papillary muscles that kind of hold up your valve can be infarcted, and that's what causes that valve to fail. So mitral regurgitation is a huge complication. And then arrhythmias, they can, because there's damage to the heart, the normal conduction, the electrical conduction is affected. So that puts you at risk of arrhythmias. And that's why on the wards, they actually keep the patients in for a while and put them on telemetry and measure what their ECGs are doing. They can go into cardiogenic shock if enough heart is damaged. It can lead to heart failure. DVT strokes. Have you guys ever heard of Dressler's syndrome? Yep, okay, good. So what it is it's very uncommon, but 2 to 10 weeks after myocardial infarction, what can happen is it can form autoantibodies. So that damage, your heart, your immune system can form antibodies that actually go and attack the heart itself or something, and that causes the pericarditis. So okay. Just moving on now to this. So you guys have a path exam. It started with our year as well, and unfortunately, this is the kinds of stuff you do need to learn. I'll leave that for you to do later. I'm sorry. Okay, so now onto the circulatory system. So over here, what I want to talk about is the difference between your left and right heart. You might have heard that term before, but I'll just kind of clarify what that means. So your right heart kind of involves all of these things. So it's your IVC going into, and your SVC going into your right atrium, and your right ventricle over there. But your liver is also kind of connected to that directly, and obviously your peripheral circulation as well, and then your JVP as well. So if you can imagine, your IVC directly joins the right atrium, and there's no valve or anything. So that the JVP directly correlates whatever's going on in your right atrium. So it's actually a really important sign to look at. So if you have right heart failure, what can happen is you'll get the raised JVP, and then peripheral edema, all that, by the end of the day, all that excess fluid accumulates in your ankles, so really important to ask the patient about. And you also get venous congestion, so they can actually have abdo pain or an enlarged liver, and that's another path term you guys will learn about, the nutmeg liver, but that's basically just like venous congestion, because the side of your heart is failing, and all blood and fluid is backlogging and kind of extravasating in these areas. Then onto your left heart, it's more connected to your lungs. So if you have left heart failure, everything's kind of going to backlog into your lungs and lead to APO, essentially acutely. Or on history, you would want to ask about paroxysmal nocturnal dyspnea and orthopnea. So how many pillows you're sleeping on at night, because it's all correlating how much kind of fluid is collecting in there. And then for APO, these are your signs, so your signs on x-ray. Another thing doctors like to ask you on the wards and stuff. So each letter stands for things, so alveolar edema, or the bat wing sign as well, so look at the hilum for any like congestion around there. Curly B lines, cardiomegaly, effusions, and dilated upper lobe vessels. So those are your signs for APO. Now onto heart failure. So it's when your cardiac output can't meet your body's demands. And it can be caused by ischemic heart disease, or other things that kind of put extra pressure on your heart and cause it to not function as well. Some risk factors are old age, and again, those things I mentioned, those 5 things you always should ask about in your history. So family history, diabetes, hypertension, dyslipidemia, that kind of thing. And then with heart failure, you can classify it with the New York Heart Association classification. And this table might look overwhelming, but it's not that hard to remember. Basically, for class 1, they're okay. They can still work out and they don't really get any symptoms. And they're not overly fatigued or anything like that. Class 2 is when they do get some limitation when they do any form of physical activity, but they're fine at rest. Class 3 is when there's significant limitation, but they're fine at rest. Yep, and then class 4 is they're just bad all the time. Okay, so there's other ways to classify it. These are taken from SARTAC slides from last year. And I talked about left and right heart failure already, but another way you can classify things is with systolic versus diastolic dysfunction. So systolic means contraction, right? So something's wrong with the heart, so it can't pump properly. So if you have like a dilated or floppy heart, it can't contract normally anymore. So that's what could cause a systolic heart failure. And then with diastolic, that is talking about filling. So something's wrong where it can't fill enough. So if your heart's severely hypertrophied, or if you have a restrictive cardiomyopathy, it limits how much space is there for the heart to actually fill with blood to pump to the rest of the body. And with that, again, you hear these things called an S3 or an S4 heart sound. And I personally always found it really hard to remember which one was which. But I found, well, my brother found a good way to remember it. So S3, he's like, S3 is, just remember, is S3 is free. So free as in it's dilated, so it has lots of room. So S3 heart sound is when you have a dilated ventricle and blood's kind of like ricocheting it around. Whereas S4 is the opposite, so it's more the strict, like stiff ventricle. So thanks, Summer. All right, so symptoms and signs. Again, this is more for your notes, so you know what to ask on history and what to look for in exams. But essentially, it's just think of right and left heart failure and where fluid could go. And that's what you want to ask about or try and elicit on your exam. Okay, so investigations-wise, bedsides, you want to do ECG and rule out, you know, heart attack, or try and look for an etiology of what caused. So you can see old infarcts as well on ECG. So do that, and then blood sugar as well. On the cardio ward, a lot of diabetes is actually diagnosed. People don't even know they have it until they come into the ward. So it's really important that you always do blood sugar levels on these patients because diabetes is such a huge risk factor. Then on bloods, you do FBE, UEC, CMP. I always mention UECs because when you're listing this off for an OSCE, you can always check in a UEC because you need that before you decide to do any imaging with contrast. So that's a good backup thing to have in your mind. But for specifically in heart failure, why you'd want to do it is you want to assess what their fluid status is looking like because they are, keeping in more fluid and whether they have any kidney failure that's exacerbating everything as well. LFTs because of the hepatic congestion that I talked about before. And then BNP, which is a really, really important blood test for heart failure. So it's released when your ventricles are strained and when there's a lot of fluid and it's being stretched, that's when the BNP is released. And it helps you kind of determine whether this patient is short of breath because of COPD or heart failure. And if they have significantly raised BNP, you're thinking it's more the heart failure picture rather than their lung disease that's causing their shortness of breath. Yep, and then imaging, chest x-ray, looking for those APO signs, importantly. Do an echo, and echoes are really great because they'll show you whether you have the systolic or diastolic dysfunction, can help you figure out the etiology, and just tell you a lot about their prognosis as well. So that's why you want to do the echo for these people. And do a stress test as well to see how much this is impacting them. And you can maybe consider doing a biopsy, but that's like very last line. Like you don't want to take a piece out of someone's heart unless you have a really good reason. Some good reason might be if you think they have some sort of infiltrated condition, sarcoidosis or something like that. That's when you'd maybe consider it, but ideally don't do it. Management-wise, again, lifestyle. Importantly here, you want to manage their fluids. So salt restriction is really important, and fluid as well, because you don't want to fluid overload them. And things to improve their symptoms as well, so elevate your bed while you sleep if they have like orthopnea and that kind of thing. These people are also at risk of getting a lot of infections, so getting them vaccinated against these specific things is really important. And then in terms of acute and chronic, there are again acronyms to remember this. And I must stress, with heart failure and with ischemic heart disease, you really need to know management really well, because that's what Monash likes to question you on. So with heart failure acutely, the acronym is LMNOP. So Lasix, which is another word for furosemide, so it's a diuretic to help get rid of all that fluid they've built up. Morphine, because that helps them calm down a bit, takes a bit of the pressure off of their heart, because when you're anxious, your heart's working a lot harder as well. Nitrates, again, to dilate the vessels, oxygen, and improve their posture or give them oxygen as well. And then chronically, the acronym to remember it is DABS. But what I also must stress is the D here is just the symptomatic management. So first I'll go ACE inhibitor, beta blocker, and spironolactone. Make sure you give that to those patients because this improves not only their morbidity, but mortality as well. So it'll make them live longer. And then once they've had all of that, and spironolactone is a diuretic as well. But if they still are symptomatic and still are very fluid overloaded, you can consider giving them an extra diuretic. And then You can also give them digoxin if they have atrial fibrillation as well. That's an important thing to remember because that can come up in questions. So digoxin if they also have atrial fibrillation. Why you care about mortality so much is I never realized how bad of a diagnosis heart failure can be. It's up there with, you know, a lot of cancers actually. We just casually say, oh, they have heart failure and stuff, but it's a significant diagnosis to have actually. So making sure they get the medications that can improve their life as much as possible is really important. For surgical management, you can give them an implantable cardiac defibrillator. Put in a pacemaker as well if they have bundle branches blocks or something like that, and if they don't have the normal electrical conduction present. And then last line, you can consider giving them a transplant, but that obviously has its risks as well. Okay, so moving on to murmurs now. So murmurs caused when there is something that's causing turbulent blood flow. So something's wrong with one of the valves that's causing blood to move in a way that's not normal. So this image is really good because it shows you where each valve's sound can be heard best. And then this image here kind of summarizes what all the sounds are. And also shows you S1 and S2 heart sounds. So what S1 is it's your atrioventricular valves closing. So your mitral and tricuspid valve. That's your S1, and it's always in sync. So that closes, and then your heart contracts, and it pushes blood either through your aorta or your pulmonary artery. And that's where you can get splitting of your S2 sound. So your S2 sound is composed of the aortic and pulmonary valve. So if you hear the word a split S2, it means that those two valves are closing at some time apart and not together. And why that could happen is, for example, in atrial stenosis, it can happen. So what stenosis means is there's some process going on that's kind of causing the valve to stenose and decrease the diameter of how much blood can go through. So in atrial stenosis, your heart's trying to pump a certain volume across, right? But because it's stenosed, it's going to take a while for all that blood to actually go through. So that's why it'll take longer for the atrial valve to close. So that's why the S2 sound will actually be split, and it'll take longer, which you can see over here. So the A2 valve actually is now closing after the pulmonary because it's taken a while to squeeze that blood through. So that's what it means by having a split S2 sound. Okay. And then in stenosis, what can happen as well is your heart, in response, it hypertrophies. And so when that happens, you get this thing called a pressure-loaded apex beat, if you've ever heard of that. So what that means is because there's this like strong, muscly heart now, when it beats and you feel for those heaves, you can actually feel it. But it won't be a displaced apex beat, which is actually seen more in regurgitate, like atrial regurg, when your heart actually expands because there's more blood than normal in there. So the atrial valve is faulty, and so your heart contracts, blood goes up through your aorta, and because that valve is faulty, blood gushes back into your heart where it's not meant to be, and that causes your heart to dilate. So on examination, you'll have the volume-loaded apex beat, which is actually when your apex beat will be shifted. So it's not going to be where it's normally at. So that's what the difference between pressure and volume-loaded apex beat. You guys also may have heard of the term narrow or a wide pulse pressure. So I'll explain what that means. In stenosis, atrial stenosis, you have a narrow pulse pressure. And what that means is, so normally your blood pressure is 120/80, right? That's the average. But because it's stenosed, you can't push blood through at that same level, so you're not going to reach that 120 that you normally get in systole. So you'll get around, let's say, 100, but your diastole will still be normalish. So now it'll be 100/80. So it's more narrowed, that gap. So that's what narrow pulse pressure is. Whereas in regurgitation, you still get that normal amount. So you still get that 120 during systole, but during diastole, that blood gushes back down. And so your diastolic blood pressure drops significantly. So it's not 120/80 anymore. It will be like 120/60. So that gap is much more wide. So that's what those two terms mean. On this slide, this is everything you need to know about valvular heart disease on one slide. And this is really, really important because valvular heart disease is so easy to ask questions on. It's so buzzwordy. You just need to memorize these certain things and easily answer questions. It's not like, oh, I don't know if this is right. It's like, oh, this is right or this is wrong. It's very black and white, I feel. So that's why I think it's really important you get your head around it. And I do have some tricks that I use to memorize what is what kind of murmur. And I'll explain that in this table. So atrial stenosis, that's the one murmur I can memorize easily. It's ejection systolic that radiates to the carotid. So if you know that, you can actually work out every other murmur just from that. So if everything that's in like the top portion of your heart, so that's going on will be the same, if that kind of makes sense. So atrial stenosis and pulmonary stenosis will be the same kind of murmur. So atrial stenosis is an ejection systolic murmur, and pulmonary stenosis will also be an ejection systolic murmur. But then when you go on to the bottom parts of the heart, it's actually the opposite. So where atrial stenosis was an ejection systolic murmur, down here it's going to be the mitral regurg. That's the systolic murmur. Okay, so just remember it's kind of the opposite. And no, don't look at those. Okay, and then all the murmurs on the top that are systolic murmurs, they're all ejection systolic. So just remember, anything up there is going to be ejection systolic, whereas everything on the lower part of your heart is always going to be pansystolic. And then once you memorize that, you can work out everything else. Okay, so now going into the specifics more. So aortic stenosis is that calcified aortic valve, and it's calcified to a point where that valve, the sound can radiate up to the carotids. Aortic sclerosis, however, is when it's kind of stenosed, but it's not to the point where it can radiate upwards. The cause is most commonly just to old age. So it's kind of like atherosclerosis, but of your valve. So over time, it gets damaged, and when it gets damaged, calcium kind of deposits in there, and it becomes calcified and slowly becomes more and more stenotic. So if you're listening to a valve on the wards or a heart, and you hear a murmur and it's an old person, you can guess it's probably aortic stenosis if you don't know. And the consultant asks you, and you'll probably be right, because most old people do have that. But do listen to their carotids to make sure it radiates, because if it doesn't, then it's more sclerosis. Okay, and then other things they'll have is a slow rising pulse, again, because they couldn't generate that strong contraction. And then the narrow pulse pressure and volume loaded apex beat, which we already talked about. And then the triad that they present to when it's really bad is SAD. So syncope, angina, and dyspnea. So that's when aortic stenosis is really bad. So that's all you need to know about aortic stenosis. Now moving on to aortic regurg. It's mostly due to something that's causing the aortic root to dilate. So if you have Marfan's or something like that, you're more likely to just have stretchy vessels, and it can stretch up and cause that valve to become faulty. Or if you have a dissection, it can dissect back and actually ruin that valve as well, which is really dangerous. And then we've talked about the wide pulse pressure and the volume-loaded apex beat already. With aortic regurg, this is the murmur that has all the weird signs. So the Corrigan or Watson-Hammer pulse. So if you feel their pulse, it's kind of fine here, but as soon as you raise their arm up, it drops. You can't feel it as well. So that's that. Demusset is the head bobbing in tune to their heartbeat, which they get. Quincke is this weird pulsation they get in their capillary beds, and trobe is this pistol shot over their femoral artery. So it's just a bunch of weird signs, but those are all kind of related to one murmur. So if you get a question with some weird sign, you can probably guess it's aortic regurg. Now moving on, I'll just do all the things on top first. So we'll talk about HOCM now. So HOCM is one of the cardiomyopathies, and it stands for hyperobstructive cardiomyopathy. So what happens in this condition is you get hypertrophy of more of the intraventricular septum, and that kind of impedes onto your aortic valve. So it's kind of essentially like an aortic stenosis. But the way you can differentiate HOCM from aortic stenosis is it's louder on Valsalva. So Valsalva is something that increases your intrathoracic pressure. So a way you can do that is get the patient to put their thumb in their mouth and kind of blow hard against it to try and create that, build up the pressure. And why it makes the murmur louder is because it's kind of putting this extra pressure on the heart, and that kind of causes the septum to bow even more, kind of making, you're kind of squishing the heart and accentuating the aortic stenosis, essentially. So that causes the murmur to become louder. In a question, it'll usually be a really young guy who has it, and he suddenly collapses because he can't maintain the cardiac output because this huge mass is obstructing his outflow, essentially. So young person with ejection systolic murmur, louder on Valsalva, you're thinking HOCM. Atrial septal defect, this is also an ejection systolic murmur. And it's basically, there's a hole between your atria. And one thing that can happen there is you can have paradoxical emboli. So normally if you have a DVT, it's gonna maybe like result in a PE, right? That's what the normal progression. But if you have a atrial septal defect, that clot can actually go where it's not meant to be. So it can result in strokes or things that aren't typical of a DVT. So that's what paradoxical emboli means. And if you guys are wondering why this murmur is ejection systolic, the process behind it. So basically, the blood flows from your left atrium to your right atrium, but that blood flow isn't enough, or it doesn't cause enough turbulence to actually make that murmur. It's just flowing through. And then that extra blood goes down into your right ventricle, and there's a lot more blood than normally is there. And all that extra blood is now being forced through a pulmonary valve that isn't used to that level of blood. So it's essentially creating a pulmonary stenosis, if that makes sense. You have so much blood that's squishing through this pulmonary valve. And so it's an effective pulmonary stenosis in a way. So that's why it's an ejection systolic murmur as well, if you were interested in the mechanism behind that. And then when it comes to pulmonary stenosis and regurg, you don't need to know much. Yeah, that's all I know about it as well. Okay, and then going on to the murmurs on the bottom now. So starting with tricuspid regurgitation, it's a pansystolic murmur because it's on the bottom, and we discussed why. We discussed how to remember that it is that. The cause is most commonly, it's an infective endocarditis in an IV drug user. So they've put in a needle, and normally Staph aureus lives just fine on your skin, but now they've pushed this bug into your blood, or into their blood, and it travels and infects that valve first. That's the first valve it comes into contact with. And then it become faulty. The signs associated with it is the raised JVP, again, because it is directly connected, and dominant V wave, and then the pulsatile hepatomegaly as well. So those are kind of the two things you need to remember for tricuspid regurg. VSD, just remember it's pansystolic. You'll learn more about this in PAEDS next year. Mitral regurg, it's also the pansystolic murmur, and this one radiates to the axilla. So there's only two murmurs you need to remember the radiation for, and this is the second one. And like I mentioned before, it's after you've had a myocardial infarct, most commonly, or rheumatic fever as well. And what can happen here is because you have that faulty valve, when your heart contracts, blood goes up into your atrium and it dilates it. And that's really bad because that affects the normal electrical activity within your heart and can create little ectopic foci predisposing you to atrial fibrillation. So that's another connection you need to memorize for mitral regurg. And mitral stenosis can also predispose you to atrial fibrillation. But that's more because your atria kind of hypertrophies, and that can be seen as the bifid P wave because it's your left atrium that's being hypertrophied. And this one is most commonly due to rheumatic fever. Okay, all right, quiz time. So first question, I'll get you guys to read it, and then let's see if any of you guys know the answer. Does anyone want to have a guess as to what it is? Okay, well, maybe I'll just go across the room. Sorry, do you know what it is?
How?
60, yeah.
I'm going to go A.
Yes, why would you choose A?
It's kind of reminiscent of an NSD element, SES, with the typical crushing chest pain.
Yeah.
With ST depression. Only very minor ST depression.
Yeah.
If the troponins were elevated, it would go there. Otherwise,
Yeah, that's really good. So the answer is A. And yeah, because it does sound maybe like an ST elevation, but with unstable angina, you actually can get transient ECG changes. So you can't exactly know for sure if it's unstable angina or an NSTEMI until you get your blood results back, really. So the fact that the troponins are still pending makes you a bit, it steers you away from choosing unstable angina. If they said, oh, the troponins were fine, you can maybe argue that that was the right answer. But yeah, okay, good job. Okay, here's the next question. Yeah? Okay, I heard the answer. Yeah, good job. So the answer is Hockham. There's another thing that affects young people. So this is a question released from the faculty. I haven't taught it to you guys yet, but let's see if any of you know it. Does anyone know it? Okay, can I pick? I feel like you guys know it. Do you know it? Yeah, good job. So this is Wolff-Parkinson-White. So what Wolff-Parkinson-White is you have this extra pathway called the bundle of Kent. And so this is another area where current can flow through. And normally, you don't want that to happen. You specifically have the AV node to kind of slow conduction to allow time for the ventricles to fill with blood. But now that you've have this kind of extra pathway, that time gets a bit shortened. So that's why you get the shortened PR. But this pathway is an abnormal pathway. So normally, think of it as like current flows through your heart like a car's driving down a highway. Like that's how your heart has been designed. But because this is an abnormal pathway, it's kind of like you running through water. It's not meant to be there, so it conducts more slowly. So that's why you get that delta wave. It's slowly going through that abnormal pathway until it reaches, and spreads through the ventricles normally. And why it's really bad is because it doesn't have the normal or equal refractory period. So you can create a re-entry circuit, and that's what can kill them. And if you imagine they have atrial fibrillation, it's just absolutely awful because every single signal could potentially pass through, and it can cause significant mortality. All right, so next question. This like has literally every buzzword I could think of. Do you guys know what it is? Yes, it is that. Good job, guys. Yeah, that's what I mean with murmurs. It's such an easy way to get marks. You just need to memorize the things with them. This is the JVP waveform. You can watch this YouTube video that explains what's going on, but you could also just memorize this table, which is all the buzzwords you need to know with JVPs. And here is another faculty release question. So like I said, management is really important. So you knowing the drugs for heart attacks and heart failure is really important. Do you guys know what the answer is? Yep, so it is ACE inhibitor. Yep, because of, unless you have renal artery stenosis, that's the only contraindication. And do you guys know what HMG-CoA reductase inhibitor is, what that is? Yeah, good job. That's like the one mechanism of action I know. It's a good one to know. Okay, another question. Well, we haven't gone over this yet. Let's see if you know it. Does anyone want to guess what it is? C. Yep, good job. So it is aortic dissection. What's going on with the arachnodactylian palatal deformity? Do you guys know what he has? Marfan's? Yep, that's what he has as well. So that predisposes you to aortic aneurysms and dissections. Okay, so now moving on to aortic aneurysms. So this is where there's a dilatation of at least 50% of your lumen. So that's the definition. There's a bunch of like classifications that you can get that I've put a picture of up there if you'd want to know. But basically, a true aneurysm has all the layers of the artery, so the 3 layers. Whereas a false aneurysm, there's kind of a breach, and blood goes and collects into like a sac made of connective tissue and stuff. So it's not the normal arteries walls that are containing this aneurysm now. And dissection is when there's a break between your intima and media, and it's creating a false lumen down there. So most commonly, the cause is, aneurysm is atherosclerosis, actually, which I never understood in the start, because I'm like, if you have this plaque, doesn't that make your artery stronger? But what's happening there is you have this plaque between your intima and media, and normally your media, part of the artery, gets its blood supply via diffusion, but now you have this chunk of plaque in there. It can't get its normal nutrients anymore, so it kind of dies off and like balloons outwards, so that's what causes the aneurysm there. And in most people, it's most commonly abdominal and below your renal arteries, so that's where you'd get the aortic aneurysm. Whereas if it's due to hypertension, you'd think it's more proximal, because that's where the most damage would happen. You can also get bacterial infections that cause it to become dilated, so that's what mycotic aneurysm is. And then specific things like syphilis can cause it, and then connective tissue disorders, just their connective tissues are more fragile and prone to dilating than normal. On clinical presentation, the one thing you guys should know is the triple, or the triad of the ruptured AAA. So they have the pain, and with this pain, it's severe epigastric pain radiating to the back. With all cardiac conditions, it's really good to know the character of their chest pain, because that'll help you answer questions. So this one is epigastric radiating to the back. You can also feel the aneurysm, so that's what the pulsatile abdominal masses over there. And if it's ruptured, they'll be severely hypotensive, because they've just lost a lot of blood. Yes. All right, and then thoracic, they have different symptoms. So if it dilates enough proximally, it can, again, cause aortic regurg, or it can compress on things. So on your windpipe, or your trachea, causing stridor, on your recurrent laryngeal, causing the hoarse voice, or your SVC, causing SVC syndrome. Investigations you'd want to do, if you think they have ruptured, take them to theater immediately. This isn't, like, time is so critical in these cases. But if you do have some time, things you'd want to consider: FBE, blood cultures if you think it might be infective cause, ESR-CRP if you might think it's inflammatory, and importantly, coags and group and hold if they're ruptured. Because they've lost such a significant amount of blood, you want to know if they can clot normally and what blood to give them if they need. Imaging-wise, abdominal ultrasounds are highly specific and sensitive, so that's usually good enough. But if you're planning to do surgery, you can consider doing a CT angio. And then onto management. So if it's ruptured, you'd want to take them to theater immediately. But before that, do your doctor's ABC, make sure the patient's stable. Insert 2 large bore cannulas and fluid recess if need be. And then, do your ultrasound if they're stable enough, and cross-match them, because they'll probably need blood. And then get them to theater essentially as fast as you can to repair it. But if it's small and not ruptured, these are the things you can do. So just regularly follow them up and control their risk factors, because it is such a risky procedure. you're not going to put them through surgery unless you really need to. And below is when you really need to. So when they become severely symptomatic, or it's really large or growing faster than a normal rate, that's when you'd want to consider giving them surgery. And you have two options. So what you can do is you can do it via stent. So they go through I think those are your iliac arteries, and place a stent in there. Or they can just place a graft in there and sew it, and they actually just sew the aneurysm around the graft. So it's like double security around there. So those are your two options for aortic aneurysms. Now moving on to aortic dissections. So that's when you have the breach in the wall, creating that false lumen between your intima and media. And how you can classify it is into Stanford A and B. And the anatomical landmark you need to memorize is the left subclavian artery. So that's what differentiates the two. And why you care about this is it affects your management. So Stanford A, you usually manage surgically, whereas Stanford B you manage medically. Risk factors, males are more at risk, and then just older age. But if you have a connective tissue disease, you'll present earlier. So like our question, it was a younger guy because he had Marfan's. And then etiology-wise, mostly due to hypertension. So just that sheer force can separate the intima and cause that false lumen. Yep, and then symptom-wise, so the character of this chest pain is it's described as severe and tearing chest pain to the back. So again, really important to know the character of chest pain. And then other signs they can have is the asymmetrical blood pressure or pulses. And it can even be absent as well. Investigations you want to do, so because they have chest pain, you'd want to do an ECG to rule out any infarcts. And bloods, those are things you'd want to do. Importantly, again, blood group and hold as well, because you might need to give them blood later on. And then the chest x-ray sign is the wide upper mediastinum. So this was actually in our exam last year. The patient had a wide and upper mediastinum, so it's buzzword for aortic dissection. And gold standard is the CT. Management-wise, you'd want to give them analgesia for their pain and just try and reduce their blood pressure to not make that dissection worse and not tear even more. And then type A is the one you want to manage surgically, and it's the proximal to the left subclavian. So get them into cardiac surgery, and they just replace it with a graft. Whereas type B is managed more medically, so you want to just try and lower the blood pressure and try and make sure it doesn't get worse. Onto atrial fibrillation. So I haven't gone over all of the arrhythmias in this presentation, but atrial fibrillation is one arrhythmia you need to know quite well, and it is fairly common as well. So basically what happens is you get a bunch of these ectopic foci developing within your atria, which is abnormal because normally you just have your SA node that creates the signal, and it normally passes through in that fashion. But now you have a bunch of all these foci in there. And so you don't get that normal P wave anymore because that was normally created by the SA node. Now you have all these fibrillations. So there's no P wave present. And with all these random foci, some of those go through at like random rates. So that's why they have that irregular rhythm as well. So if you see no P wave, irregular rhythm, that's atrial fibrillation. So causes for that, it can be valvular heart disease, and we talked about why, because stretching of the atrium just predisposes more of those foci to develop. And then those are some other causes. Another important one, or one I feel like I should maybe highlight, is alcohol. That came up in a question for us as well. So alcohol can induce atrial fibrillation. It's this thing called holiday heart syndrome. So yeah. And hyperthyroidism as well can cause it. So those are the etiologies. Clinical presentation, they can be asymptomatic. So that's with a lot of arrhythmias. They can just be fine. But if they do have symptoms, it's shortness of breath, fatigue, can lead to heart failure, syncope as well. And then the most kind of classic buzzword thing for them is the irregular pulse. So as soon as you feel that, that's when you know. And then ECG, you can see that. So there's no P waves present, and the rate is irregular. Bloods you'd want to do is thyroid function tests, because I said before, hyperthyroidism or thyrotoxicosis can induce this. UECs, and then cardiac biomarkers to see if there's any damage to your heart as well. Imaging, chest x-ray, and echo. Looking for the left atrial thrombus. So in atrial fibrillation, because there's more stasis within your atria, it predisposes you to form a thrombus in your left atrium. And this is something that they really care about when it comes to management. And you're thinking of cardioverting these patients. You don't want to cardiovert a patient when they could have a thrombus present, because when you cardiovert them, that thrombus can just go and infarct something. So you want to make sure it's not present, or you break it down before you decide to cardiovert them. And now onto management. So the way to memorize this is the acronym RACE. So R stands for rate control. So first line is beta blocker, but if they're asthmatic or there's some other contraindication, you can give them a calcium channel blocker. And like I said before, digoxin if you have heart failure. So I've mentioned this twice already, but heart failure and atrial fibrillation, give them digoxin. Then onto anticoagulation. So because there's stasis within their heart, they're at risk of forming clots. And this can be an auscultation, by the way. So explaining why a patient is going on warfarin. Acutely, you can give them a heparin and calculate their risk with the CHADS-VAS score, which is over here. So each letter stands for something. And then depending on your score, you decide what treatment they'll get. Oh, I don't know if okay. Yeah. So 0 aspirin or nil, and then 1 warfarin, and then warfarin or aspirin, and then warfarin or NOAC. But also with this, just the fact that you're female, you already have a score of 1. So, sometimes doctors do take that into consideration, whether putting someone, a female, just because she's female on warfarin or not. Okay, so first you acutely. So with atrial fibrillation, if you acutely get into it and the doctors find out within enough time, they can actually cardiovert you and you can go out of it and you'll be fine. But if you've had atrial fibrillation for quite a while, your heart kind of remodels and you can't really cardiovert out of it anymore afterwards, if that makes sense. So you're kind of just stuck with the atrial fibrillation. Yeah, okay, so now onto the cardioversion part. So how they can do it is if it's been less than 48 hours, they can just DC cardiovert you. And they put you under anesthetic and stuff. They don't just shock a normal person. But if it's been past 48 hours, that's allowed time for blood to kind of pool within your heart and create that thrombus, which I was talking about. So they first anticoagulate you and then DC cardiovert you. But you don't have to go the DC cardioversion route. You can also use medical cardioversion, and that's with drugs such as flecainide and amiodarone. But each one has its side effects and why you wouldn't use it. So flecainide's good for young people, but not great for the elderly. And amiodarone has significant side effects like pulmonary fibrosis and hyperthyroidism as well. So weighing up those causes. And then you want to treat the underlying etiology. So if it's caused by the hyperthyroidism, you want to go treat that, or the alcohol, CSAT, that kind of thing. So that's atrial fibrillation. Again, important to know how warfarin works because that can be an OSCE explanation. Okay, onto pericarditis now. So this is inflammation of the pericardium, and it's normally, it's idiopathic or viral caused by this virus called Coxsackie-B. And with this, they have this really characteristic chest pain, which they describe as kind of stabbing chest pain. That's better when they lean forward. And when I was on the wards, my first week in cardio, there was a patient and he could barely speak English, but he literally used the word as a knife was stabbing me. So it is very characteristic of pericarditis. And then on auscultation, you can also hear the friction rub as well. So those are things for pericarditis. Another important thing to know about it is its ECG. They like to show this a lot. So with pericarditis, the very typical things are they have PR depression, PR interval depression, so it's lower than the baseline. And then the ST elevation, they call it saddle ST elevation. That's kind of global. You can see it in quite a lot of the leads. And that's very characteristic of pericarditis. So when you see that, that's pericarditis. So that's what you do bedside. And then bloods, FB, UEC, ESR, CRP to see if it's any inflammatory cause. UEC you'd want to do because of uremic pericarditis. So if you remember from when you learned your renal exam back in the day. And then you'd also maybe want to do blood cultures and viral serology if you think that might be the etiology. Imaging, chest x-ray and echo. And then you can also do pericardiocentesis, which is not only diagnostic, but also therapeutic as well. So yeah, they basically, they just take a bit of the fluid out. But that's more if it's like tamponading as well, that would be more therapeutic then. But management-wise, you just give them an NSAID and treat underlying cause and give colchicine if the NSAID isn't enough. When you're giving a patient such high doses of NSAIDs, you also give them a PPI because it puts them at risk of peptic ulcers. So just give those two together. And then if you think the cause is autoimmune, you can also give them steroids. Because things like SLE and that can cause pericarditis as well. Now onto tamponade. So this is when there's excess fluid now within the pericardial sac, and it's enough to kind of put pressure on the heart and actually compromise the diastolic filling and now the cardiac output of the heart as well. It can be secondary to acute pericarditis as well. And post-MI, like I said, if you've had that rupture, you can get blood into the sac as well. Symptom-wise, or clinical presentation, it's Beck's triad. That's another important thing you should probably memorize. So Beck's triad is hypotension, distended neck veins, and muffled heart sounds. And you can also get pulsus paradoxus. So I never understood that before, but I understand the mechanism now. So pulsus paradoxus is when on inspiration, your blood pressure drops by 10. And the reason behind that is, so when you inspire, what basically happens is your diaphragm moves down and your chest wall moves out as well. So it's kind of like if you take a syringe and like move the plunger down, you're just sucking in air. That's what you want. But it not only sucks in air, it actually sucks up blood as well. So blood goes back into your heart. And so now you have extra blood within your right heart. And normally that would be fine because your heart it's dynamic, it can move. But now in cardiac tamponade, you have that extra pressure on the heart. So instead of kind of moving outwards now, the intraventricular septum bows to the other side, so bows towards the left. And now the left ventricle has become squished because the septum's gone onto that side. And so less blood fills the left ventricle. And so when the left ventricle pumps blood to the rest of the body, it's less than normal. So that causes the drop. So that's pulsus paradoxus. Investigation-wise, again, it has a very typical ECG pattern. First of all, it has very small amplitudes, and that's because you have that excess fluid, so the ECG can't pick up the signal as well. But it also has this thing going on called electrical alternance. And why that happens is your heart so there's that extra fluid, and your heart is kind of moving back and forth as it beats. So when it beats once, it might be closer to the chest wall and the amplitude might become larger. But then when it beats again, it might move back and more of the fluid goes in front. And so the amplitude becomes smaller. So that's why there's that alteration. It's like the heart moving back and forth. So that's electrical alternance, very typical. This is an ECG you should probably know as well. And then bloods are kind of the same. Imaging-wise, you can get this thing called the water bottle sign. So it's an old school water bottle that the heart looks like, apparently. And then the special test you want to do is the pericardiocentesis. So that can help you drain out the fluid, and then you can send that off to find out the cause of why they've gotten this tamponade. So it could be, infection, malignancy, TB. So that's why you do want to send it off. If it's non-acute and if it keeps recurring, so if it's like due to malignancy, they can create a permanent window. So that can allow fluid to just drain out if it keeps happening again and again. To prevent that from happening. And yes, in the acute setting, you can just give IV fluids to improve their output. And then it's really important to treat the underlying cause for whatever it is. Okay, so we're nearing the end now. There's just infective endo and rheumatic fever left. So infective endocarditis, it's an infection of your endocardial surface. And this is a table kind of saying which pathogen happens for what kind of scenario. And again, it's something you guys need to memorize, unfortunately. And then with infective endocarditis, it can either be acute or subacute. And with acute, it's normally a normal valve that it happens with, and it's a very like virulent organism. So it just kind of attacks it and obliterates it, and they become severely unwell really fast. Whereas subacute, it's a mildly virulent one, and it's like the heart's already been damaged in the past, and it's not as much of an acute presentation when they come into you. And their recovery is also okay. It's not as bad as the acute endocarditis. With this, it's really important to memorize the antibiotics you use to treat them. So with the native valve, you give them IV Gent. Gentamicin covers your gram-negatives. Benpen and Flucox, which kind of cover your more gram-positives. And then with your prosthetic valve, you want to make sure you give them Vanc to cover MRSA, I believe, as well. So important things here to memorize are this table and then the antibiotic therapy. So clinical presentation-wise, you can break it down into like constitutional things. So they're just feeling unwell, fever, malaise, that sort of thing. Cardiac, they can get a new murmur because it's infected their valve. It can make it faulty. And it can even form abscesses that can leak out and cause pericarditis, and can also lead to heart failure as well. So make sure you screen for that on your history. And then extracardiac are the things we learned in the cardiac exam. So the Osler's nodes, Janeway lesions, the splinter hemorrhage, and then it can cause septic emboli to just flick off from their vegetations growing on the valve. So they just might have parts of their body that start infarcting. Investigations, ECG, because of that abscess forming, it can cause conduction blocks. And then you'd want to do a urinalysis just to see that their kidneys are doing okay, and that it hasn't gotten infarcted as well. And importantly, do a blood culture. So how you do blood cultures, I think this is another thing worth knowing, is they do 3 blood cultures, and they do an aerobic and an anaerobic one. So they take 2 bottles, and it has to be taken 1 hour apart and from different sites as well, just to make sure they know for sure which bug is causing this. And then you do chest x-ray and echo to see if there is any damage or if they can see the vegetations. And the criteria is Duke's criteria. You might hear that term, and it's down here below. Yep, so that's that. And now on to rheumatic fever. So this happens after you've had a group A strep infection. So those are things that cause, you know, pharyngitis or tonsillitis, that kind of thing. And then like a few weeks later, you get kind of an immune reaction. So the antibodies that were created to fight that infection actually now go on and start fighting your heart, which is not ideal. And then it leads to, you know, myocarditis and all these arthritis as well, because it affects your joints as well. And that kind of thing normally presents in younger children in developing countries. And that's the clinical presentation. It also leads to these skin lesions as well, erythema marginatum. And this thing called synonym chorea, it sounds very strange, but the people become emotionally labile and just start having weird dancing like movements as well. And their speech may become explosive as well. And that's one of the things in the Jones criteria. So Jones criteria is what you use to diagnose rheumatic fever, and Duke's was for infective endo. So you might hear those terms, and that's what they are. So investigations want to do ECG, check for any damage there, try and do throat swab to find the infective organism, and then do your analysis, because the group A streps can cause post-strep GN as well, so you want to try and make sure they don't have that going on as well. Bloods, you do all the same we're used to, but importantly add the anti-streptolysin O antibody, so the ASOT titer, because that's the thing that's causing the rheumatic fever. And then chest x-ray, echo. So Jones criteria is down below. So the way you can memorize it is it's strep pace. And that's convenient because strep is the most common causative organism as well. And down below is listed what each thing stands for. The rheumatic nodules are the Aschoff bodies. So that's another path buzzword you guys should probably memorize, associated with rheumatic fever. And then complication-wise, you can get the myocarditis, pericarditis, and valvulitis as well, so causing the valvular heart disease. And now that you've kind of damaged your heart, it predisposes you to get infective endocarditis, like we talked about before. And when you have myocarditis, it's inflammation of your myocardium, so that affects your heart's ability to pump, first of all, so leading to heart failure. And then arrhythmia is just because there's inflammation going on and your normal conduction isn't present or is affected. All right, and just below, I have this drawing of a face. So that's what I use to memorize what antibiotic to use for strep throat. So if you see, I've like drawn a red V like around his mouth. So it's penicillin V. That's what you use to treat strep throat. And another word is phenoxymethylpenicillin. So if they still have the infection going on, you can give them penicillin V to treat that. And yes, okay. Last thing, here's just a table again of chest pain and like what kind of chest pain is with what condition. And again, really important, I can't stress enough how you need to know these. And yeah, that's all. Thanks for listening, guys. Just one last thing, there's this book, I highly recommend you guys use it. And it has a lot more questions and it gives a good description for the answers as well. So I highly recommend you guys use that to study. And yes, that's it.
Congratulations.